It's me, Jen, again, and today we're hearing from 3 different surgeons about their experience with a non-surgical procedure. Stick around. When patients seek a non-surgical treatment option for their thyroid nodules, they're often very hesitant of talking to a surgeon. Often they feel the surgeon is only going to offer them surgery because, well, that's what they do. But today I'm introducing you to 3 surgeons who have decided to offer a non-surgical treatment option for thyroid nodules, radiofrequency ablation. In this video, you'll hear exactly why these 3 surgeons stepped out of their normal treatment modality into one that is changing the landscape of thyroid care as we know it. Make sure you watch to the very end of this video to learn the key takeaway I learned from talking with these surgeons. First, we'll meet Dr. Henry Reinhart, an endocrine surgeon in the very southernmost tip of Texas.
The main thing I hear about thyroid surgery is that it's very important that you have a very high volume thyroid surgeon if you're going to have thyroid surgery.
You hit the nail on the head. The outcomes, especially in cancer surgeries, are so much better, and there's such a smaller risk of morbidity after the surgery, having problems with your surgery and recurrences when you go to a high volume surgeon. And that's key, high volume. Doesn't have to be an endocrine surgeon, but just as long as they're high volume. Problem is, it's the vast majority, like something like 80% of all endocrine surgeries are done by low volume surgeons. The safest time to do any surgery is the first time.
Yes.
It becomes increasingly difficult every other time. So the best advice I could give anybody if they need to have surgery, make sure they're a high volume surgeon.
Yeah.
The reason I'm doing this is because I truthfully think it's probably the next step in thyroid surgery, thyroid care. I think for a lot of stuff, including a lot of more indolent cancers in the next 10 years, it's going to be the treatment of choice. And I already do most of my clinic-based procedures myself. I do all my own ultrasounds, all my own biopsies. So it's like a natural addition for me. And the nice thing is that anything that can't be treated with RFA, I can take you to the OR. It's kind of a full service package. What I'm trying to do is get the pathologist to come to me so we have one big day so I can just give them their diagnosis and say, hey, we can watch this, get an ultrasound in a year, or you need surgery, we should take this out, and tell them on their first visit. That's the end goal. I don't think many ENTs, general surgeons, do their own biopsies. It's a big added benefit just solely for the fact that I do the ultrasound, so I kind of see where everything is. I see if a lymph node looks suspicious, right? So ultrasounds normally aren't done by doctors. They're normally done by techs. And so techs measure what they think is important, and they send those images to the radiologist. So the radiologist can only read what is sent to them, right? If they miss something that's small, that doesn't meet criteria, they ignore it. But I see like 6 millimeter cancers all the time, and I'm like, oh my God, that's cancer. I'm sure that the thyroid probably does some things that we're still not even aware of that might not be supplemented with thyroid hormone if we give it to them post-operatively. So I jump at the chance to leave thyroid behind if I can whenever I do surgery for that exact reason. If you leave half a thyroid, you have about a 70% chance of not needing any medication. So I always think it's worth that shot. Even if they have nodules, I'll say, let's just watch it. If I ever have to go back, I can go back. I'm comfortable doing that. But this gives you a chance of not needing any medications. You know, if you don't have to take one pill for the rest of your life, that's a win. So if they had a nodule that was growing, 2 centimeters, but otherwise the thyroid is fine, I think that's a great option. And one thing I've also incorporated into the practice is something that's actually hurt me as a surgeon. We do molecular or genetic testing.
Yeah.
All the thyroid nodules we biopsy, and I used to operate on probably 40 or 50% of the nodules that came to me. And now with this testing, we've narrowed that down much, much more, because with that testing, previously suspicious stuff is now returning as benign. It's what's in the patient's best interest. I really feel like RFA is going to change endocrine surgery as we know it. I think in 10 years for these much less aggressive cancers, that this is probably going to be the go-to option, and watchful waiting. So the studies in the US are just going to have to show that it is beneficial, because some of these guys are practicing surgery the same way for, 30 years, 35 years. I think the first 2 steps is to get it paid for by insurance and show the data. And the data is just now being collected here in this country, in the US at least. Probably in the next 5 years, I think we'll see it being covered by insurance, and then it's just going to blow up.
My next guest is Dr. Robert Brebrick, a general surgeon located in Wassau, Wisconsin.
I've been in practice in surgery since 97 or something. Every week I do 3 to 5 thyroid surgeries. As a surgeon, you have a certain advantage over non-surgeons in terms of the anatomy. And, I think that I had all the pieces that would allow me to do this. So in terms of the anatomy and stuff, it's very much familiar. And then in terms of the ultrasound, it's something that we've been doing for 20 years. So my perception was it's not going to be one of these procedures that's going to fade with time or that will be discredited. I think it's going to expand with time. There's definitely people that want it. It's nice to have your thyroid, even if you need a supplemental. If you're making some and you have some autoregulation, but you need some additional, it's kind of like you're pedaling a bike uphill and you get to the crest of the hill and you need somebody to give you a push. You're doing a lot of it on your own, and that's probably a good thing. And some folks find it hard to get the right adjusting dose on that. What I like is it doesn't burn any bridges. Say if you do surgery, somebody's had a parathyroid operation, but then you go back in and you have to redo something. It can be quite difficult. There can be a lot of scarring, and there's just an increased risk of a nerve injury, and technically more difficult, easy when it's a de novo, first time surgery. So doing the RFA, everything is kind of inside the thyroid. So technically you shouldn't have any external inflammation. And my understanding is that it doesn't make a subsequent surgery harder. So I like that. That's a positive. It is an intervention. It is invasive. It's really how you treat a problem. It's a different solution where you want to get a certain result. And it has advantages, as we've talked about, the preservation of thyroid function, the avoidance of a scar, the avoidance of a general anesthetic, and a quick recovery. If for some reason you needed to, you could repeat it. And there's always the option of surgery down the road, should that be necessary. It's more looking at the problem and how to solve it, and not so much, well, I'm only going to do surgery. What you want is the best results with the least intervention. And I think I could definitely see that. And there's no reason you can't mix and match. You want to solve the problem in the best way. This is legitimate. And let's get on it.
My last guest is an endocrine surgeon from Raleigh, North Carolina, Dr. Kirk Faust.
I've been doing just endocrine surgery for about the last 18 years or something like that. All I do is operate every day, all day long. There are times when the problem is simply a structural issue that bothers the patient. You can project in the future that it'll be a bigger problem later. Somebody who's young with decades of life expectancy and has a big structural issue, they're kind of only left with surgery, which is fine and works very well. But more important than that, if you take out a portion of somebody's thyroid gland, there is a real possibility they may have to be on thyroid medication. Not everybody does well on thyroid medication. Most people do. Maybe they started doing remote access thyroid surgery 10 years ago. It became sort of popular in the United States. And that does work, but it's really not a very good technique for malignancy. You can't do it in big nodules. Its only advantage is the lack of a surgical scar, but it's really extraordinarily invasive to avoid the scar. I saw offering radiofrequency ablation patients who really didn't want to have surgery. They were worried about the scar. They wanted to sort of avoid that experience. I saw it as an alternative to that kind of approach. And it was much more simple, and it gave the same outcome that people wanted. So I thought, wow, this looks perfect for that. If you want to just deal with the structural issue, I think it can be a pretty effective technique. I don't know how many fine needle aspiration biopsies I've done in my career, but it's literally thousands. It was a pretty easy learning curve to kind of transition from needle biopsies using a lot of the same techniques that I've used my whole career to subtly adjusting it for radiofrequency ablation. I think that's a big plus. And that's one of the reasons I think that it can supersede other surgical techniques. It's a very, very exciting and very good technique for the right patient with the right sort of structural issue. The use in people that have sort of hyperactive, smaller nodules that have always required surgery before to deal with them. And this technique would be perfect for many of them. In smaller nodules, say 2, maybe 3 centimeters, that you really think that you can see it completely and get a total ablation on it, that could be a real great technique for them.
Talking with these 3 surgeons showed me 3 common threads. Number 1, if you do need surgery, experience matters for good outcomes. Number 2, RFA is a natural fit for endocrine-focused surgeons. And number 3, RFA provides the best possible outcomes for patients. If you're considering radiofrequency ablation to treat your thyroid nodules, consider this very important takeaway. Surgeons who are trained in this procedure can offer you a uniquely balanced perspective between RFA and surgery because they're skilled in both areas. If you're interested in reaching out to any of these physicians, you can find their contact information in the description below. Make sure you subscribe to this channel so you don't miss the full interviews with these doctors coming very soon. Thanks so much for watching. Subscribe and ring that little bell so you don't miss the next video in the Surgeon series. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.